Good morning, everyone. Right, so we had a really good discussion here, starting up this morning. All right, I love it. Starting the day, right, starting the week with inspiration, right. So, learning the things that you knew beforehand, but practicing them to kind of restart some of those pathways to for memory, right, muscle memory and things like that, and then also self advocating for yourself so that way the medication reconciliations, you get the treatments that you need, the interventions that you need, so that way you can manage the symptoms and better engage in life. Man, I love that. Right, so keep that up. Thank you very much for modeling that for everybody. And so we'll get started here today, this morning, module 10. Right, we're almost done. Right, and so still have some time here together, and we'll talk about future upcoming programs and ways to keep connected so that way we can keep updated on your progress. Right, so here, module 10, we will be discussing beginning care planning. And then module 11 will be, well, what are the available community options for those things that we're planning here today? So we'll be using the newly updated clinical practice guidelines from the National Academies of Science, Engineering, and Medicine, which will be published by the summer of this year, and the Arabi guidelines. So before we get started, disclaimer. The opinions voiced in this workshop are those of the host and do not necessarily reflect those of Providence St. Jude Medical Center. The content provided in this workshop is for informational purposes only and is not intended as medical advice. Please consult with a healthcare professional for advice regarding any medical condition or treatment. And so, while not mandated, please keep any and all information shared amongst ourselves and other attendees confidential and within this virtual room. If any information is shared that makes anyone reasonably suspicious that abuse of a child, elder, or dependent adult is occurring, I must break confidentiality in these circumstances. And for Zoom etiquette, please remember to mute your microphone when you're not speaking to reduce the background noise. If you would like to speak or ask a question, please use the hand raise function at the bottom of your screen. And as a reminder, these meetings are being recorded as well as each of the 12 morning sessions in this workshop series. There is an afternoon session that is longer than 1 hour and will not be recorded to facilitate discussion amongst ourselves. Should you be more comfortable with attending the later session instead, you may elect to come to one or the other or to both on any given week, right? Earlier we had someone who's gonna show up to both, right? So we're gonna be hanging out all day today. So the recording will
Me.
become yeah, that's right. Yep. The recording will become available as soon as possible via email and our YouTube channel. And the recording will only include presenter mode, so no one's video will be shared, and your voice will only be recorded if you speak. Otherwise, please use the chat raise function to answer questions instead. And so, um, starting off here today, right? The homework, right? Is to do one emotional cycle every day this week. Your choice of event, right? And at the end of the week, read through them and identify any patterns, right? So we're looking at are there triggers, sensations, thoughts, or behaviors, and how all of that cycles around your emotions and your emotional experience. So does anyone have any insights or any patterns that they would like to share or would be open and comfortable with sharing?
I'm gonna say that all of us have different triggers or what sets us off. So
Yeah.
so we just emotions are someone else does something, you react or overreact. So I'll have different things. Yeah.
Yeah.
I'm the same way. Like
Yeah. 100%.
I gotta work on the triggers. Those are my biggest downfall.
Mm.
Yeah.
I have positivity when it comes to sensations and some thoughts and behavior, but it's the triggers
Set
that
you off.
I find that I don't recall prior to the injury if I had major triggers. But now the slightest thing sets me off.
Right. Yeah. So and it's as you're talking about, and it comes on quick, right? Like it comes on so quick that it sometimes I can't even make a decision whether or not to react.
Oh yeah, I snap.
Yeah. Yeah.
You
And
know,
so what are some of those triggers for you?
uh, for me, it's pretty much like anything. You know, unfortunately, it's my kids not wanting to hang out with me when they come home from school. Um, my mom, we live at the house all together. Snaps. It's like they know what sets me off, and I
Mm,
know they don't do it intentionally.
yeah.
These things, they push me to the link, or not to the link, the brink.
Yeah. Yeah. And so it's like uh it sounds like your kids, fans, there's a lot of people in the house, and so the overstimulation is triggering.
Yeah, my
Yeah.
wife as well, same thing. Like
Yeah.
she tends to avoid me throughout the day.
Yeah. Yeah, and so for those triggers, right, as we're talking about right here, so have you been able to incorporate any of those strategies to avoid the either to manage the triggers? So it's either avoiding the avoidable ones or preparing for um
I do. I try my best.
yeah,
And
yeah, so
I think everyone has triggers that
yeah,
they try to avoid. They do their best to,
yeah,
but with me, it was more so I'm an alcoholic, but I haven't had a drink in a long time. I mean,
congratulations.
for me it's going on like 9 months.
Hey, that's fantastic,
8 or
right? So
9 months probably. Something like
yeah,
that. But yeah, I mean, that used to be my go-to.
right, coping.
Yeah. I don't want This is one thing like I never wish I drank. Unfortunately, it's embedded in my genes.
Right? It becomes a habit, right? As we kind of talk about those automatic kind of habits, those coping things, right? And so that's an example of like maybe when neuroplasticity can not be such a great thing, right? It's that
Right.
automatic, right? Yeah, and so have like you've identified some triggers, right? Try to avoid best you can. Have you thought of other ways that you could prepare for those like unavoidable triggers? Like you can't always avoid your kids or your wife, and so have you thought about ways that you could prepare for some of those triggers?
I mean, I try. I do.
Yeah.
I try and have as much communication with them that I can. But
Okay.
I I I think now I know how and I know when to walk away before it escalates. You know what I mean?
Yeah. And so I that's great, right? Like being able to like walk away before it escalates, and then also communicating, right? Increasing the communication with those that you are interacting with.
Yeah,
I know that one of the kind of strategies, right, is to walk away, but then also communicate. I'm going to take a break for 5 minutes or 10 minutes. I'll be back, right? So that way, when you walk away, the people that you're communicating with are expecting, they know where you're going and that you're coming back. Have you been able to communicate any of that as you walk away?
I try.
Okay,
Everything
good.
I do, everything I do, I try. And when I walk away, I just, you know, I let them know, like, look, I need to recenter. I'm gonna go away, but when I come back, I'm ready to talk.
Hey,
In the
that's
right frame of mind.
there you go. I love that. I love that. So I mean, you're essentially avoiding what you can, and then preparing for like I'm coming back. I'm gonna need a break, da da da, and then when I come back, I'll be in the right state of mind. So that way you're facilitating
Correct.
communication with your loved ones.
Correct.
Hey man, that's beautiful, man. Thank you for modeling that. Right? Miss Katie, you had something there?
Yes. Thank you, Travis, for sharing your experience. I have to helpful to be reminded to walk away. Thank you so much. Yeah, I received a transcript from this research project I'm in, and it was about reliving a very emotional situation where our senses got overwhelmed. And so we had to describe it. And when I looked through the transcript, I was horrified at how many times I said like, um, I, I was just horrified. I could barely understand what I said. Um, so that really made me feel bad.
Right. And so I appreciate you sharing that, right? So I mean, part of that is also using a strategy by recording and seeing the transcript as a way to help you with what we've been talking about, the metacognitive strategies, right? I need to self-monitor so that way I can adjust or change or find some ways to fix that, right? And so here in the center, you felt bad, right? You had a negative emotion here, right? Um, and that negative emotion came from the trigger of really seeing I how much I used I stuttered, I used the word like, and I felt bad. So what were your thoughts there?
I went through the transcript and whited out every nonsense word there was, which didn't leave much.
Mhm.
And then I thought, I need to speak to my speech therapist and tell her I want to practice how to answer a question, stay on topic, and what the heck can I do to stop talking like that? Of course, I'm being really careful right now because paranoid.
Yeah. And I love that. I love that, right? I mean, there are some thoughts like, okay, maybe this is something like I can't, maybe it's because I can't express my thoughts clearly or in an organized fashion. And so that's also contributes to my bad feelings, which are facilitated by the triggers. And so the behaviors that I used was I did something progressive. I went to my speech therapist and I told him or her that, hey, these are the things that I'm having issues with, and I would like some strategies on how to best and most effectively address some of my concerns. Right?
Yeah,
Love that.
yeah.
So
Well, I
that
haven't
way,
been to her yet. Yeah, but yeah, that's what I'm going to do. So, yeah, I thought she was crying at the end. She was crying. Like I thought she was moved by my testimony, but I think she was horrified, like in anguish. Like I've listened to this, like oh, it was awful. But yeah.
yeah. And so what were some of the sensations that you felt in your body when you went through the transcript?
I felt sick, nauseated. Um, I felt nauseated.
Feel nauseated, and then that further contributes to the negative feeling or the emotions that you had there in the center. How would you describe, like, what emotion word would you use to describe the bad feeling in the center?
Is horrified on there?
Horrified, yeah. So you were scared, right? So there's a degree of fear in there, right? And then that also then feeds back into the thoughts. What were you scared of?
How I was torturing somebody with my speech.
Uh, right, torturing someone with your speech, right? And have you and who is this person? Were you able to debrief with this person?
Um, after talking about my experience, yes, we did debrief, and she played the ukulele for me, and she was really sweet.
Oh
But
man,
I
that's
haven't talked to anybody about how awful I sounded. Mm-mm.
so I mean that's good that you bring that up here. So I appreciate you being vulnerable, right? So that scared feeling, that horrified there from the triggers, the sensations of feeling nauseated, right? And then your thoughts of like, oh, okay, it's not organized, or I'm, um I'm putting someone through trying to listen and make sense of what I'm saying. Ultimately, that's putting to a behavior where you could not say anything to anyone. But then what you did there, and I love it, love it, love it, love it. What you did there is you then instead of isolating and continuing to stay isolated and avoid people, right? Because like, oh, I have bad communication skills, so I'm just gonna avoid all people and never say anything to anyone. That's what you could have done, right? But instead, you chose a constructive behavior, and I'm going to bring this future behavior, right? I'm going to bring this to my speech therapist so that I can better address and have strategies to more effectively communicate my thoughts so that way next time I am with someone, I can think of like, oh, okay, well, I'm working on it. I'm getting better at it, right? I have these strategies, I have these skills that I've been working on and practicing, so that way my horrified feeling of emotion of hearing my voice and the way I communicate can be improved. I love that, Miss Katie. So thank you, thank you. That is a really positive and progressive, right? Yeah, yeah. No, clap on that. Yes, absolutely, right? That's great, Katie. I love that. Right, perfect. And so we have an emotional cycle here regarding one thing that could have been socially isolating for Miss Katie, right? But instead as is becoming a progressive and constructive behavior. Same with Travis, right? Like instead of avoiding your kids, avoiding your wife, I mean, you can't do that all the time, right? Because then that's further going to isolate you. And so instead, Travis and Miss Katie have identified behaviors and ways to prepare for the triggers that can improve their interactions moving forward. Love that. Love that. Yes, Kat, you had something? You had something?
Yeah. So I didn't write down much because I am buried in paperwork and things get buried in all my berries of paperwork. But I was just working on being more aware of what my triggers are, and there's way too many of them. And the whole emotional cycle chart that just eventually sends me back down the spiral of, I'm not good enough. Just crawl back in my little hole. But what I would like to figure out, and I kind of was doing it for a little while, I don't want to go through the whole emotional cycle
Ow.
all the time because it
Oh.
exhausts me. I just want to be able to like stop a second after the trigger. And for a while, I was just like when that negative, when a trigger happened, I would just literally like just flick it off with my fingers, like to say physical. Okay, let it go. You're gone. Vamoose. To just stop it. But I actually haven't thought about that until just now for a couple months. So I find something that kind of works and I forget about it. But
Yeah.
there's just, but being aware of how many things that I don't even know if they're all triggers or if I perceive them as a trigger. Somebody else might go, really?
Right.
But we our triggers are what we perceive them to be. And I would just like to cut it off the second it hits, just like, okay, flick it off, you're done. I'm not going down that cycle 25 times a day. Every time I go through that whole emotional behavioral cycle, I just spiral back down to, I'm never good enough for anything I do. or for anybody I'm with, and just go crawl back in my hole. So that's what I would like to find, better ways to just disconnect. If the trigger happens, flick it off. Okay, I don't need to go there. Been there, done that. Not good for me. But then I forget that's what I want to do, because I have a short-term memory issue. So
Right, right. And so I mean that's similar to what Rosie was saying, right? The triggers are all different for everybody,
yeah,
right? And
yeah, they
so
are. Yeah,
and to
and somebody
different
else might
degrees.
go. Somebody else might say, "Well, why would that trigger you?" Well, you know what it does.
Mhm.
I mean, I own my triggers, but it's just. But my short-term memory is pretty crappy,
Mhm.
and one of my triggers is people that are very dismissive of what we go through with head injuries. Oh, you look
Right.
fine. Just do it. Just figure out what you need to do and do it. Had
Right.
one the other day. It's like, oh well, if you don't remember things, just put lists all over the place. Well, yeah, but
Yeah.
then you can remember to see the list. I can have a list up on a cabinet and and see it. It doesn't like even.
Right. Or even people are saying like I'll write it down. Okay, I write it down, but then I forget where I wrote it down on.
Oh my God, I've got piles of paperwork just buries me. I'm a master list maker, but if you can't find your list, or if you don't remember to look at the list that's in the middle of the table, or taped in big letters up on your cabinet, it doesn't even like register
Yeah.
in my brain.
Yeah. No, I mean that's great, right? So I mean, yeah, like you've identified some triggers, right? Is when
Yeah, too
I'm in
many.
experience interactions that might either invalidate or I can't find my list or where I wrote it or I forget to look at it, and then the emotion there in the center is frustration. It sounds like.
Yeah, it's frustration and overwhelm. And then it just, yeah, the thoughts just, okay, one more thing of, I remember, and I need to get this out of my head, because somebody who's no longer my friend on my choice told me
Mhm.
one day, oh, that's just one more, one more, um, just more, like, I can't think. It's like one more proof that, you're totally incompetent and worthless.
Mhm.
Somebody I thought was my friend for years. And I just told her I might ask her to help me remove a mirror, because it's
Yeah.
heavy and I have to climb on a ladder, and I am really not safe on ladders. And she goes, oh,
Right.
well, just more proof. That was it. Just more proof how incompetent and worthless you are. And I'm like, wow, okay, I
Yeah.
need to walk away from this one. But
Yeah.
that is rent free in my head. And it was there rent free years before I met her.
Yeah.
But that's, oh yeah, yeah, that's the rent free. I need to
Yeah.
I
No,
evicted her out of my life. I need to evict that out of my life. But that's a lot
evict,
that
right?
comes
That
up. It's like,
Yeah, I mean that's a great point, right? I see hand clapping there, right? People, other people had nods, right? I see you there, right? Because what you're talking about is like the short-term memory or the invalidation from others leads to the thoughts of like, okay, well maybe I am incompetent, I can't do this, and then ultimately the
yeah.
feeling, emotion there of worthlessness, and then the sensations, right? What's your body saying at that time when you're thinking of
Um carb
thoughts that
cravings. Yep, just go for the chocolate, go for the carbs, which really make me feel awful. And then I justify eating more chocolate and carbs because I already feel like crud, and I might as well go have some more. Yeah,
yeah,
it triggers all these. It's not just a spiral. It's like the pictures where somebody's got their finger in the socket and their hair is all like just it's boinging out of control. So one trigger, which is about trigger A, can just zing off in 35 other directions. It's
I mean
exhausting.
that's exactly right, right? Like the triggers for one thing can lead to another cycle that lead to another
Yeah,
cycle, and
it's like,
all of those
yeah,
things affect each other,
yeah, it's
right?
exhausting. And then
Yeah.
I just can't
Exhausting.
function.
Exactly, right? And so when we can start identifying, well, which trigger was the trigger that kind of activated all these other cycles, is as you just said, maybe this thought of incompetence, this thought of worthlessness that comes from someone else that's living in your brain, as you said, rent free, right?
Yeah.
So now, what are some things that I can do to evict this person or this thought, right? And
Yeah.
and so those behaviors, I think one of the behaviors, right, you said is increasing awareness, right? Maybe not writing it down, but at least bringing awareness to these things and sharing these thoughts, with us, sharing these thoughts with, others, right? So that way we can address some of the concerns that you're talking about, right? And so there are strategies in that blank emotional worksheet, right? There are strategies for all components of these that we can address. So, one of the maybe things for triggers is either avoiding the avoidable, prepare. A second is preparing for triggers that are unavoidable, or three is seeking out the desirable, right? So, for you, it sounds like improving. I think I remember a goal that you shared early on was improving sleep, improving some of your social interactions. And so how
Yeah.
have those things been for you?
And that's what well, the sleep is, it's still rough. I had to send back the APAP machine. I couldn't do it for my ears. I can't handle the pressure. So I was taking a little bit of the CBD CBN chewies, half a one a night. Um,
Okay.
doesn't cure sleep apnea, but it helps me sleep better.
Okay,
I
good.
got really excited about that. I ran it by my sleep clinic doctor,
Good.
but it does weird things to my head. Um, Not anything specific, and I've talked to other people that have eaten the chewies. A lot of people, they just really work well, but
Mm,
it puts me in on an edge of a not good space. I'm already on that edge too much.
mm.
Um, and it was making me really dizzy during the day, so I had to stop, and now I'm back to just massively sleep deprived. But as far as friends things go, yeah, I have been working on reaching out more to the friends that I know that don't belittle or dismiss me,
Right.
and and I just have to remember that I am not anyone else's priority. I wasn't anyone's priority when I was married a couple times, but um, they
Mhm.
all have their own lives, and I think they value me. But I'm on the edge of their lives, and sometimes that's just kind of hard. I'm single by choice, and
Mm.
normally it hasn't bothered me. Um, but I had a friend come over yesterday, and she brought me warm blueberry muffins she just baked.
Ooh.
And I was able to get the didgeridoo back from my neighbor because the oral surgery's healed enough. I can start learn to play it. So I went over
Okay.
there and finally got to play it, and I suck at it. It's going to take some lot of practice. And then I went
Yeah.
down to annoy another friend of mine with trying to figure out how to blow on this didgeridoo, and she invited me in for uh, some some good food. I'm like, wow. So I have to focus on those things, you know, um,
Yeah. 100%.
and that's I need to make that enough, I
Mhm.
guess, instead of feeling
Right.
like I'm not good enough because I can go weeks and never like really get phone calls, or I feel a lot of times it's a one-way thing, but that's just my perspective. Um, but
Yeah,
yeah,
and I love right? I mean, the behaviors you're reaching out, right? Doing something, things that are constructive, right? Reaching out to a friend, right? Got some good food, right? That brings
yeah,
good thoughts of like, oh, this is good food, right? And then that also
right,
ultimately improves the emotions that prepare you well for future triggers. And then moreover, you're also able to connect with your neighbor to get back to your didgeridoo, right? And
right,
as we say that like music, right? We've talked about in like week 5 or week 6 the importance of music making activities, right? And being
Well,
able to
you haven't heard me try to blow on this thing yet.
yeah, well, I mean, like,
It
like you
is
said,
so not like an unimpressive mouse squeak is what I got out of it so far.
yeah, but as you said, right, it takes practice, right? With like any
It's-
piano, I think Miss Katie, you were talking about getting on the piano, right?
yeah,
And then we're planning on creating a program where we'll have keyboards and send them out to anyone who wants to participate, right? It's
right.
all about just practicing, starting small, right? I love that, right? Starting small, and then ultimately how that constructive behavior is going to change all the cycles and then ultimately prepare you for triggers for other cycles. So yeah.
And ultimately, the reason I bought the didgeridoo is because it can theoretically help with sleep apnea by the time you learn to do the correct breathing.
Ooh.
But I haven't played it yet in the house. I just got it back last night, and
Okay.
I may go annoy the neighborhood rather than scare the bejeebies out of my cats. So
All right, perfect, right? So I mean we have a couple weeks still, so maybe we can get a concert, a didgeridoo concert.
well, yeah, I'll open the window and play it across the street so you just vaguely hear it. Anyway,
Perfect.
thank you. Yes, thank you,
Yeah, no,
everybody.
I love that, Kat. Keep it going. Keep it up and keep us updated on your progress. So that's
Yeah.
fantastic. Yeah, and you had something there? Oh, and you're muted.
Okay, sometimes I
Okay.
wish I was alcoholic so I can go to the inner AA meetings, the real AA meetings. So sometimes I have a decision, ambivalent decision. I have to choose one or the other, or what's going on, and that makes life very difficult. For me sometimes, and then the fear comes in. I went to a 12-step meeting, lunchtime meeting, very smart woman. I asked her if she'd be my sponsor. Why? Because she was smart and I'd like to see if I can work the steps. But she had a book that I'd have to read and relate to with answers. And I really do not want to do that. I did that many years ago. And I think it's a step away from the big book. I want to just read the big book, sometimes spending a day on one sentence. I don't believe in deferring. So that's my own opinion. So I stepped away and I said I wasn't sure. So then I spent the whole day afterwards, I was at lunchtime, worried about this and fear and this, and I never get what I want, blah, blah, blah. So that, I think that's a misuse of a valuable time on my part. And
Got
then
it.
I asked, well, what do I really want? Well, I really want to understand the big book directly. I do not want someone's interpretation and answer questions, blah, blah, blah. And that's what I really want. It took quite a lot. And so I'm willing to step away. But, maybe there'll be a sponsor sometime else. Maybe not. I'll be my own sponsor. So and then I thought to myself, you really don't want to spend that much time with a sponsor right now. You promise yourself piano lessons, and you have paintings. You want to go to galleries and try to sell them. That's what So there it is. This decision making, and in the meantime, and the undertone is that I have an infection, and I'm struggling with what MD can write the script so I can solve the infection. I got a call from a nurse that there's another a secondary infection because my body, of course, is uh, reacting, and they think that infection is the most important thing. You got to go to the doctor, blah blah. But they don't know that I'm firing the doctor, so to speak, because she's really not helping me. And I found a doctor who potentially could treat the first infection with the needed medication I need. Now you ask, why can't I get all this up front? I have no idea. Is this what happens when you're 80 years old and they say, toodaloo, you're done? I really don't know. I really don't know. I give up. But I did find two doctors, my rheumatologist, and I'm thinking of leaving real early this meeting to get to the rheumatologist because I believe and tell him what's happening. And I think he understands the undertone of why I have the infection to begin with, and he'll do it. So,
Right.
yeah.
And that's great, right? I mean, really here you're taking really constructive behaviors
Mhm.
towards finding the doctors that you need, right? Based on the symptoms that you have, right? And
Mhm.
having those discussions, right? A constructive behavior, so that way you can get to the source of the frustrations that you're having, right? And part of that is also stemming from what you were saying earlier, is not really uh, hearing interpretations of the big book, but really knowing for yourself, right? So part of that is also like better understanding. I need to get my own interpretations of this, of what I'm reading, so that way the triggers can be managed. Right, I can manage those. I can manage my emotional responses because they're my interpretations, right? And so part of that, I think, is huge, right? The 12 step, right? Wanting
Mhm.
to, your comment earlier is like, I kind of wish I was an alcoholic so that way I
Yeah.
could get to the real 12 step, right?
Yeah.
And so part of that is you're really wanting more directed social contact and
Mhm.
social support with those who understand intimately, right? So part of
Mhm.
that is also kind of tying in what Kat said, Travis, Miss Katie, right? That the social connection, right? The social support, and to
Mhm.
really understand. And my favorite saying in the big book is the serenity prayer, right?
Mhm.
Lord,
Yeah.
grant me the serenity to accept the things that I cannot change, the courage to change the things that I can, and the wisdom to know the difference. Right? Seeing head
Right.
nods in the place, right? So love that, guys. Love that, and so keep it up. Keep us up there on your progress. Whatever the doctors say regarding your
Mhm.
infection, keep us updated.
Okay.
Yeah, you had something there? Yeah, and you're muted, Pam.
Did you talk to? Oh no.
Um, this might be inappropriate for this recorded meeting. I just wanted to mention that there are Zoom meetings for AA. They're open meetings, and they are for the big book. And so the each person who's attending, reads a paragraph or two, and so that might be an option for Anne. And
Oh.
again, I apologize if this is out of turn. And
Oh
also,
no, that's perfect, Pam.
okay,
Like as we say, right? Sharing of any resources, great.
Darlings, I live
Appreciate
that every day. That's part of my life. It's not, I've been living this since 1987, and it's my life. And now last 2 years Zoom meetings. So it's yeah, because I think it really made my survival. And once yeah, so I'm very grateful to Sue G, my first sponsor. Oh, of course. And of course, these meetings are recorded and there are podcasts. If you miss a meeting, there are podcasts on all
Oh,
these things. It's
oh,
just wonderful.
perfect. Yeah. So yeah, I appreciate that, Pam, right? Sharing the resources is very important. Maybe if you can share the one that you like in the chat, so that way if there are people who are interested, we can contact and connect with those resources. So thank you, Pam.
yes, and I will take this one opportunity. Anne, if I had a choice, I would choose you as a sponsor in a heartbeat. Thank you for all you do.
Oh.
I pass now, and I'll put that in the chat. Thank you.
Okay. Yep.
Thank
Thanks
you.
so much.
All right, thank you. Awesome. So really love that, right? All of the things that people are sharing, right? The cycles, right? Being vulnerable, right, are huge, right? So thank you very much for being able to share those things. And there's a lot of commonalities, right, amongst all of our cycles here, right? What are we doing to prepare for triggers so that way we cannot engage in non-constructive behavior? How can we continue to instead engage, and then how that engagement, that social engagement, can then prepare us down the line for impacting the behaviors, to impacting our emotions, and then preparing us for future triggers for other cycles, right? Love that, love that, love that, right? So, what we're going to be discussing today, right? So, keeping in mind your cycles, right? So those are important. So if you got your cycles that you have from the week, continue to look through them, because those cycles will be really important as we continue to plan our care, right? Short term and long term. So initially, first we'll talk about kind of the subacute to post-acute care, right? So if you were involved in a medical episode of care, right? So these are some of the things that are important, right? For, first 6 months to even a year, and then to consider, have these been done with you? Let's say you are within that time frame, or let's say you're outside of that time frame. These are some of the things that that are starting to be considered, that should be considered for future survivors. So if you have not, maybe it's something to then consider in your care planning. So again, these are from NASM. And so the final draft has been completed. Here are the recommendations for 6 months, maybe to even a year, right? And so we'll talk about each of them individually, so that way, if you're on your phone, you can get all 11 of the recommendations, or 11 topics. There are 17 recommendations over 11 topics. And so this is really foundational on the idea that long-term care planning begins with really the post-acute care planning. So long-term starts with figuring out the plans more immediately, right? Or in the post-acute phase early on. So that way you can better plan later on. So these 11 topics have been out for external review right now, with planned completion in next month, early next month, and then with formal full publication planned for June of this year. So this is kind of an event. Yes, absolutely, right? Claps, claps, claps. The Action Collaborative of TBI Care, amazing work. Such an honor and a privilege to contribute and be a part of it, and to really just witness this great advancement in the management and care of TBI. So really the objective and scope of this guideline is to improve post-acute clinical management of community dwelling adults with TBI who are able to care for themselves, right? I think Kat was saying, oh, you look fine, right? What's the problem, right? So at hospital discharge, if you are fortunate enough to experience an episode of medical care, or let's say you don't require acute hospital care, right? So you weren't in the hospital for long term, you weren't in a coma, right? But still, like, these are some issues that are persisting, that seem to be either invalidated or not understood. And so these guidelines are really for that specific population. So and really the funding for this Action Collaborative of TBI Care is funded through the Wheel Family Foundation and Maurice Marciano Family Foundation. And so we have the disclaimer there. And so the CPG working group followed the ADAPT process, right? It's a systematic approach to synthesizing and adapting existing clinical practice guidelines. And the guidelines that were used were living with concussion guidelines from Ontario, various physicians from emergency departments, occupational therapists, physical therapy, the VA DoD. And so really this is based on the idea that traumatic brain injury is a bump, blow, or jolt to the head that disrupts brain function, right? And these alterations can result in things like motor incoordination, headaches, memory problems, or some mood difficulties, right? And TBI is a major public health concern that has garnered increasing attention from researchers in recent years, with annual estimates of up to 74 million sustaining a TBI globally, right? So it's clearly a growing and considerable public health concern. And that was clear when in Washington, D.C. at the beginning of the month. And so the first guideline here is to really confirm the diagnosis of TBI. And so here are the recommendations. Clearly, I mean, really, and you'll have these in the slides. But really, it's to influence whether the severity, the TBI severity of the head trauma. And so if you've had a CT or an MRI, so those shouldn't be considered all the time. But if you do have a CT or an MRI, which are primarily structural, or they are structural brain scans that may not show the functional impact, right? But let's say if you did have them, they are really meant to just rule out anything more involved, right? Like a skull fracture or hematoma, things like that. Yes, Kat, you had a question?
I've had several CAT scans, and the doctors seem to think that, oh, well, your brain's not cracked, so nothing wrong with you. Like, okie
Yeah,
doke.
yeah,
It doesn't
yeah,
work that
right,
way. Just because I don't have, my brain's leaking out doesn't mean I'm not injured.
right. Yeah,
But
true. And based on
yeah,
this ATRM criteria, and I also linked the article there at the bottom. So if you have the slides, you can click that link to get to the criteria. Like the diagnosis, like turns out, in neuroimaging or even neuropsychology aren't necessarily even required for a diagnosis of TBI. So those could basically the diagnosis is really based on like injury mechanism, and then signs and symptoms, and then physical examination. So those things can be supported by like objective tests of balance, cognition, right? That's where neuropsychology comes in, or vestibular ocular motor function, right? So your coordination of your eyes and your vision and your movements, and then imaging if it's even conducted, same with blood-based biomarkers if it's even conducted. So like there are also consideration of additional factors, right? Like maybe there is an exacerbation of pre-existing or comorbidities that then in context of a head trauma or brain injury may facilitate new symptoms that may mimic or mask TBI signs and symptoms. So like it's really, as Kat, as you were saying, it's very complicated, right? And it requires a very specific lens to identify signs and symptoms and what they may or may not be attributed to, right? And so the second guideline is to determine whether an ED evaluation is required. So for most of us, this is fine. If not all of us, I mean, we're out of the hospital and we haven't had for a while, but there may be some other symptoms, right, that may be considering, well, why or when you should go to an emergency department. And so these are things like declining or fluctuating level of consciousness. So if you ever have that, right, this is why journaling is important. So that way you can track any symptoms. Are they getting worse? Or if there's new onset of like pupil asymmetry, so if the sizes of your pupils are different, like you have increased seizures, maybe you're nauseous or vomiting. I think Kat, you were saying I felt nauseous. I feel nauseous, and so maybe if there's repeated vomiting, right, or there's marked change in behavior, or severe or worsening headaches. So using your journal to track these symptoms are important, right? And so that's where they may be some other symptoms, so other concerns that may be helpful. So, for example, if let's say it's after a head trauma or a head injury, either for yourself or someone else, you're noticing that they have raccoon eyes or battle sign. So battle sign is the discoloration behind the ear. Raccoon eyes is there shown on the right. These are concerns that maybe after a head trauma, you may want to consider a visit to an emergency department. And then third is to characterize the investigation and effects, to characterize the effects of the TBI or your brain injury. And so part of this is most clinical practice guidelines really only address the need for neuroimaging in an acute setting, or for atypical presentations like headaches that are strongly positional. So from sitting down to lying down to sitting up to getting up, and based on symptom course. So if you have progressing or worsening symptoms, these may be clinical indications for neuroimaging. And then, we also talk about formal neuropsychological assessment. So these may be offered to inform planning to return to sport, school, or work, or guide treatment in patients with persisting symptoms, right? And cognitive symptoms that are disabling and not getting better, right? So for that's would be a situation. So if you fit into this would be a situation in which a neuropsychological assessment may be important. And so if you're within a year, right, a formal neuropsychological assessment may not be indicated because your brain's still getting better, right? So there may be some considerations here, especially when requesting neuroimaging or neuropsychological testing. If it's not functionally or clinically indicated, that's a major reason why healthcare providers don't order them, right? So it's not that they're hiding or they're keeping things secrets from you. It's not clinically indicated, and more so if the neuroimaging came back and it was normal, it's very likely not to change the clinical management of your care. Right, so these are some of the concerns, right? Like it has come up before, so and part of these workshops is to better frame so that we can understand why certain things happen in our healthcare that aren't necessarily what we want, right? And so really a big part of is a number 4, right? That's made it to these clinical practice guidelines is screening for social determinants of health, right? Especially when abuse or neglect is a suspected cause of TBI, right? Because if abuse or neglect is a suspected cause, there may be additional things like acute stress symptoms, post-traumatic stress disorder that may significantly impact your capacity to reintegrate effectively, right? And so if that's a case for you, please bring those up to us, right? So that we can provide better directed treatments and referrals for some of these mental health concerns that could potentially lead to significant mood disorders, right? And then so these are also things that to understand, like social determinants of health, considering like food insecurity, housing insecurity, transportation insecurity, the needs of financial difficulties, employment related concerns, right? Because all of these things are added stress, right? And if there are cognitive concerns that are impacting that are already difficult to manage without head trauma or brain injury, then these further exacerbate and complicate and really add more level of disability, right? And exacerbate that level of disability that these situations already impose, right? And so there's also guidance on rest and when to return to usual activities. So I love that, Travis. Love that, Cat, right? Miss Katie, right? You guys have gradually returned and refused to avoid all things and really return to your usual activities integrative fashion. So this is kind of what we're talking about, moving things in a scaffolded fashion. So returning to usual activities in a stepwise fashion. So if you can take your normal activity and break it down into small pieces that move from like 4 to 5 to maybe 6 or 7 steps. So that way you can move in progressive fashion that doesn't put you in that, what we talked about in week 6, that boom bap, the pacing pattern, right? We don't want the boom bap where we do so much activity that we're then just spent for the next 4, 5, 6, 7 days, right? Or 2 weeks, right? Want to do it, re-engage our lives in a fashion that is manageable, that is small enough that we can move in a scaffolded fashion with support to slowly start increasing that in a pacing pattern as opposed to that boom bap pattern, boom bust, I should say. And so next is, of course, educating the patient, which is what we're doing here, right? We're providing these workshops, right? And the recordings and then the slides for you to bring to either your family or or, as a patient, bring to your doctors or your healthcare providers. And then number 7 is to assess the risk for slow recovery. And so some of the things that are associated with slow recovery after brain injury is the female sex, pre-existing health conditions like headaches or migraines, right? Indications of brain injury severity. So let's say you do have a fracture, or you do have a hematoma, or you do have some bleeding, or you do have some intracranial effects, right? Those become important to monitor over time. And then high symptom burden, right? High symptom burden. And so we can do this using standardized measurements. One of them is called the Rivermead Post-Concussion Symptom Questionnaire. And so if that is of interest to you, please just reach out. We can further screen you with these things to evaluate some of these prognostic factors for slow recovery. Other mental health symptoms, like we are talking about PTSD, we can screen that with a PCL5, right? That's used out of the VA DoD. The psychosocial issues, right? So like fear avoidance, cognophobia, pain catastrophizing. We did that in week, what was that, like week 5 or week 7? And then you all have your scores and interpretations. Number 7 is social determinants of health, right? We screen for those with the prepare screener. And there may be other things that help, that are strong prognostic negative factors for slow recovery, like the high burden of symptoms using the Rivermead, for example, or mental health symptoms using the PCL or PHQ-9 for depression, or GAD for anxiety. And then there's multiple other negative prognostic factors. So ultimately, what we're trying to do here is identify these risk factors and provide them to your healthcare professionals, so that way they can better understand and frame where you're coming from and understand your specific case. Right. I mean, there can be so many different things, and depending on what doctor that you see, what type of doctor do you see, they have a specific lens, right? If you're seeing a medical doctor, then like, primarily, on the average, that they're going to be looking through a medical lens. And so if the symptoms that you're bringing may not be directly medical in nature, it's going to be a very confusing medical appointment. And so really trying to bring a lot of those things to better prepare you to have conversations that are meaningful, productive, and progressive with your healthcare professionals, no matter what lens they seem to be looking through. And then part of that is, by incorporating the different lenses for different healthcare professionals, is it allows the prioritization of which symptoms to possibly treat first, right? So, headaches, poor sleep, depression, anxiety, right? Those really are the most common priority symptoms above but first, the first symptoms is in the second number two guideline that we talked about earlier. If you have any of those symptoms that be suggestive to go to emergency department or emergency room, or suicidality, or self-harm ideation, those are number one priority. And then if you're not having any of those, then headaches, poor sleep, health management, self-management, lifestyle, depression, anxiety, mood, those become the next sort of priority symptoms. And so number nine, right, it gets its own recommendation because it's so significant, right? Post-traumatic headache, right? And obviously, not all headaches are created equal, right? You can have one-sided, that would be more migrainous type headaches, there on the left. In the middle, if you're having those tension headaches, that's basically like 1,000 million rubber bands wrapped around your head, right? That's a tension headache. Could sometimes also be cervicogenic in nature, right? Maybe it's neck pain that is radiating to the head that isn't quite headaches per se. It's neck pain that's perceived as a headache, or is it full head? Right? The headache type. And so these are all different various types of headaches that could be, you could have one but not the other. And what makes this confusing is you could have all of them at different times, or you could have all of them at the same time. And so part of this is better understanding what kind of headache type do you have to better provide more individualized, tailored treatments, right? That are effective, right? And so here the first there are over the counter analgesics like acetaminophen, right? These are like Tylenol or NSAIDs, ibuprofen, Tylenol, and so those could really that you get over the counter to abort headache once they start. Also, if you have migrainous headache types, you can consider triptans. And so and when headaches frequencies exceed, so if you're doing your journaling, you're doing your cycles, and you're finding that headaches are somewhere either in your sensation or in your triggers, right? And that shows up, let's say, more than 10 days per month, and they are disabling, then maybe that would be a situation to consider prophylactic treatments like CGRP inhibitors, things like that, and all of that are all informed by this DoD, the VA DoD for post-traumatic headache. So these are recommendations that you can bring to your healthcare provider. And I see that Travis did so and got his Ajovy injections, right? And that was effective for him, right? And so part of that is bringing these kind of recommendations, these guidelines from the DoD to your healthcare provider so that they can provide better directed and individualized treatments, right? So that way you don't get refractory headaches, which you could get from like overuse of over-the-counter analgesics, which could actually then make your headaches worse, right? And we seeing head nods there, like yes, yeah, clearly that is something that's happened, right? Number 10 is screening for mental health disorders, right? And providing first line interventions for mental health disorders. And so the research has shown that a first line intervention for mental health disorders for TBI are just as effective for those in the general population. So if you're finding that you have some anxiety or depression, that which we've screened for, right? That was the initial part of getting into the courses, is we screen for that. If you have concerns about post-traumatic stress disorder, we can screen for that with the PCL5, and other disorders or conditions. If you're having hallucinations, hearing or seeing things that other people aren't, there may be some helpful things to do here. And then, so of course, if there's any suicidal ideation or self-harm, those are considerations for an emergency room or an emergency department. And also, when clinically appropriate, primary care clinicians may also initiate first line therapies, which can be mental health or can also consider pharmacotherapy or both, right? And so research has shown that a dual approach where both psychotherapy and pharmacotherapy have shown to be highly effective in treating persisting mental health conditions after brain injury or just persisting mental health conditions in general. And then 11 is, of course, when to refer to a specialty provider, which we'll talk about just now, right now. And so there are considerations for special populations. So, for example, older adults with fall risks, intimate partner, survivors of intimate partner violence. This could be where, there's a level of post-traumatic stress, right? Athletes or military servicemen members who may downplay some of their symptoms in order to return to duty or return to play faster, for example. That's one approach, is to start from the post-acute planning, so 6 months to a year. And then there's also a second approach here, which we'll talk about briefly, is a symptoms-based approach, right, to care planning. And so this is based on the DoD Clinical Recommendations, which I've linked here at the bottom. And so if your symptoms are primarily anxiety or mood, some specialty referrals may be considering to behavioral health, which we've also spoke last week, that there are some policy eligibility policies that inadvertently exclude survivors of brain injury because the source of their behavioral health concerns are primarily quote unquote medical in nature, right? So then they send you to a neurologist, and neurologist says, oh, what you have are mental health concerns. So then they refer you back to mental health, and then mental health refers you back to, and so you play back and forth, right? So there are some considerations there. So learning how to best frame your concerns as a way to get the treatments that you need. One is cervical neck pain, right? So if you've got whiplash, right, you may not have hurt your head or neck, or you may not have hit your head or neck directly, but you may have gotten a whiplash. And from that, if there are cervical neck pain, consider a PM&R if it's a physical medicine rehabilitation physician or PM&R. Also see a physical therapist who specializes in the neck, right? So that may be some concerns as well. If you have cognitive or thinking issues, right, there are the specialty providers, that is neuropsychology, right? Also occupational therapy, right? If you're wanting to get back into driving, I think that's been a huge one in the past couple of weeks, right? A lot of you guys here and in the support group have been talking about getting returned to driving. That's largely in the arena of occupational therapy, right? And there's also speech therapy, right? I think Kat used this beautifully, right? Is when I'm having concerns with speaking fluently, organizing my thoughts, communicating effectively, those may be something that you bring to a speech language pathologist, right? So these are the specialty care that you can consider. And also I put the cognitive rehabilitation guidelines out of the INCOG 2.0, the Administrative of Ontario. It was published at the end of 2023. I have linked there in the slides, as well as the DoD cognitive rehabilitation guidelines as well. Then if you're having headache, we talked about this. Those at the bottom there is the DoD guidelines for post-traumatic headache that I spoke about in the previous approach. I think it was number 9. And so the specialty referral guidance is neurology. So there is a subspecialty of neurology called headache migraine neurology. Also, if the headaches are affecting your vision, like blurry vision, double vision, right, that may be something to bring to a neuro-optometrist. Right, so that is another specialty. And also PM&R, which is the physical medicine and rehabilitation specialist. I should say, for cognitive thinking, and for anxiety and mood, right? Another specialty referral, I didn't put it here because I just thought of it, is a psychiatrist who specializes in the brain behavior relationship. It's called a neuro-optometrist, right? So there is a subspecialty of psychiatry and medications that specifically address brain behavior relationships and considerations of central nervous system disorders. And then there's ocular motor, right? So if you're having difficulties with your vision, right, this could be like sixth nerve palsy. If you're having like cross-eyed or lazy eye, neurooptometry is a specialty there, as well as occupational therapy, right? The vision interventions, some occupational therapists do specialize in that as well. Yes, Travis. Yeah, a
Yeah.
question to say?
So which one of those okay, so remember I told you I used to wear the glasses during the day. They kind of help.
Yeah.
And then I wear them at night before I go to bed. But I haven't worn them lately. But I am getting, it's not per se like double vision, but you know, it's blurry at times and it's not blurry
Okay, so sometimes it's good, sometimes it's not, so it's fluctuating.
correct.
Okay. Yeah, I mean, if it's concerning or debilitating, then it's vision therapy may be something where so it sounds like it might be not so much so because sometimes because it is fine, sometimes it isn't. Sometimes it is fine, so that's kind of showing that maybe it might be a vision therapy might be something to kind of ask for or to consider with your primary care physician to bring up to start that conversation.
Okay, so speak with somebody at the optometrist, like
Yeah,
at the
like
doctor.
vision therapy, specific vision. It's specifically called vision therapy.
Okay, let me write that one down. Vision therapist. You're good. Thank you very much, sir.
Absolutely, absolutely, yes. Anne?
Yes, I just thought of something. There's as a previous special ed teacher, I bet there's a whole population, COVID accepted, because they had no chance of being detected. The children who've had head injuries, no one ever knows, and they're not reading, and they never learn how to read. There's a
Yeah.
population out there, and it's unfortunate. I wish there'd be some program to find these 8, 9, 10-year, 11-year-olds before they get in trouble.
Yeah, perfect. So there are a number of programs, national programs that are working towards return to learn sort of protocols. So you're exactly right, Anne. You're exactly right. Kat, you had something there?
Yeah, I just wanted to chime in and encourage you, Travis, it's the neuro optometrists have nothing to do with like eyeglasses. They
Right.
will,
It's more so
yeah,
the vision. It's
but so they work with neuro occupational therapists, which is very different than your regular OTs, which are also great. But it took me my 20th concussion last year to even hear about what's a neuro OT, because they'll work with vision, and I had no idea I had all these vision issues that I probably had since 18 head injuries ago, and I probably would have been spared a lot of the last head injuries if I had
okay.
known
So
to go to
go
these
ahead.
people, because they will work with balance, they'll work with vision. I didn't know my eyes would jump up around. I didn't know when I would turn out. I didn't know why things out to the sides didn't make sense, why I couldn't get my eyes to focus correctly. So it was a walking trip hazard. And
Yeah.
so, and that's nothing to do with my regular optometrist, which gets my glasses corrected. So the neuro optometrists will work with neuro OTs, which will give you exercises to help with specifically vision, convergence or whatever weird
Right.
eyeball issues we have when we get our heads whomped. So
Right.
Okay,
just to
so
encourage you, it
a,
can be life changing.
a neuro optometrist.
A neuro optometrist and a neuro occupational therapist. At Kaiser they work together because the neuro eyeball doctor says, okay, these are all the things that are your
Okay.
eyeballs are doing, and then the neuro OT will work with you on all the exercises to help. And it really was a game changer, at least for my eyesight, which will hopefully greatly reduce my clumsiness. So hopefully I won't have any more.
Oh
It
yeah,
is.
no, I appreciate that. Like the thing with me is like prior to any of this injury to me, I had 2015 vision.
Yeah.
Right, but it's not about
Prescription per se.
yeah, it's not about your prescription. It's whether like your eyes converge correctly. It's
No,
whether
no, yeah, no, I
yeah,
understand. It's like I
yeah,
never had an issue with vision at all.
Yeah.
yeah.
Like,
So I think you're exactly right, Kat. And so it's neurooptometry, right? You can find one using the Neurooptometric Rehabilitation Association, which is NORA. And so Vanessa, can you send Travis or put in the chat the NORA visionrehab.org is the website, and it takes you to website, and if you scroll down about halfway the website, it'll give you there's a zip code finder for a provider in closest to you, and then so that way you can connect and begin the conversation to discuss vision therapy.
okay. I mean, I have
Yeah.
Kaiser, but they probably have one on hand.
Oh
Or
yeah. Yeah.
Kaiser has them, and they also have a vestibular physical therapist, which
uh-huh.
can help with balance. Never heard of those until last year. So
Okay.
vestibular PT. It's just balance issues from pretty much acquired brain trauma issues. So
Okay.
Perfect.
yeah,
Yeah,
Okay. Well,
perfect. And
I
actually,
appreciate that.
yeah,
Thank you,
bring that up
Vanessa,
there.
too.
yeah.
Yeah, so perfect. So first, sleep specialty guidelines. Clinics are behavioral health because there may be a whole bunch of other conditions that affect sleep. Sleep medicine, which is really important, and the Department of Defense, the assessment and management of sleep disorders following TBI. There's a lot of different conditions out there other than just sleep apnea, right? And so to learn more, I've linked the DoD in the slides there. And as Kat was just talking about, right? Perfect. Is vestibular, right? So and the specialty therapy here, vestibular therapy, which can be a vestibular PT. So you're exactly correct there. And
Neuro.
so um, some of the things that are impacting, right, is what factors, this is out of the Arabi guidelines, which came out in 2020, what factors influence quality of life following injury, right? And the severity of your symptoms, depression, anxiety, right? Those neuropsychiatric symptoms that could be best or could be targeted by a neuropsychiatrist, right, to get you the medications plus psychotherapy, which seems to be the most effective in terms of what's been coming out in the research. And then third is self-esteem and self-awareness, right? So Travis, Kat, Pam, Miss Katie, you've all, Pam, Anne, right? You've all talked about, like in your cycles, really talking about increasing your self-awareness and finding ways to improve and engage the life that you live, right? That you love with to increase self-esteem, right? Either connecting through social individuals, finding new hobbies, right? Learning to play the didgeridoo, learning to play the piano, right? And then, so what factors influence independence, community participation, and adjustment post-injury is the motor function, right? So emphasizing the importance of physical therapy and maybe a specialty type of physical therapy, cognitive function, which then may be an SLP if it's communication, driving, maybe an OT if it's driving, or a neuropsychologist if it's evaluating specific deficits that you're trying to address, right? Which may also be a dysexecutive syndrome, which is really more of a frontal lobe issue. And then, of course, level of awareness. In its worst cases, as the anosognosia. And so doing your journaling and the cycles to increase your self-awareness is a very direct way that you can influence and improve your independence and adjustment. And then lastly here, what are the common elements of group-based social programs that increase self-efficacy? Is psychoeducation. That's all the 12 workshop series is. And then coping skills training, right? Finding additional ways other than, turning to substances. And then part of this is brain injury resource facilitation, which I'll talk about next week. Just wanted to show you here. This is a recent publication that I just learned about when I went to DC in the beginning of the month. And so really we'll talk about this more when we talk about the community options that are available. And so we'll really talk about our homework now for next week is to continue use your metacognitive strategies to reflect on your emotional cycles, right? Self-monitor to identify the triggers, the sensations, the thoughts, the behaviors, and ultimately to identify the emotion in the middle. And then in your journal, write down as many problematic symptoms that are disabling so that we can better identify which of the community resources that we're talking about next week are going to best address or somewhat address the concerns that you're having in the journal entries that you make over this next week. And so we'll brainstorm different solutions and modes of therapy for the different symptoms. And again, here is the emotional cycle out of Mount Sinai with the blank slide with the strategies that you can download in that link in the slides that we've sent to you, which also look like this, right? So ultimately, what we're going to do to be able to improve our awareness so that way we can take progressive steps towards improving our self-efficacy, our self-esteem, and engagement in the community and the life that we love. Thank you. Have a fantastic week, everyone. Woo.
Thank you. Have a good week, everybody.
Bye.
Bye. Thank you. Thank you.